Good afternoon to everyone, and welcome to the HPV Triage Enhancing Cervical Cancer Screening in Manitoba webinar. I am Dr. Donna Turner. I am the Provincial Director of Population Oncology at CancerCare Manitoba, and it's my pleasure to be the moderator for today's session. So I'd like to start by acknowledging that we are in Treaty 1 territory, and that the land on which we gather is the traditional territory of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. So if we could have the next slide, please, folks. Excellent. And the next one. So just a little bit about webinar etiquette before we get going for today's session. Our key speaker is Dr. Sarah Kean, who you can see on the screen, and I will introduce her more fully in a minute. But before she speaks, just to let you know a little bit on how this is going to work today. The webinar is being recorded and will be available on the CancerCare Manitoba website shortly after airing. This group learning program has been certified by the College of Family Physicians of Canada and the Manitoba chapter for up to 1 Main Pro Plus certified credits. The College of Family Physicians requires that you retain proof of your participation for 6 years in case you are selected to participate in credit validation or auditing. So please keep track of your certification. We will be inviting participants or those that are our audience to ask questions, and we will be addressing them in the last 15 to 25 minutes of this webinar. Those participating via Zoom can enter their questions in the Q&A box. So not the chat box, the Q&A box. That's really important. And also to note that this is the way we will be taking questions. So there won't be any verbal questions. If you have a question, we would like you to type it into the box, and I, as the moderator, will be looking at those and putting them forward to the speakers. All right, so next slide there, please. So Dr. Kean is going to speak until about 12:40 on HPV triage, which will then be followed by an interactive Q&A with a group of panelists. So the next slide, let me introduce you to, first of all, to our key speaker. So I'm going to introduce you to Dr. Sarah Kean. Sarah is a gynecologic oncologist practicing in Winnipeg, Manitoba. Originally from the East Coast, she completed medical school at Memorial University of Newfoundland and went on to do her residency in obstetrics and gynecology there as well. She moved to the Prairies for her fellowship at the University of Manitoba and has settled here. She is currently an assistant professor in the University of Manitoba, and her current interests include cancer genetics and cervical cancer screening. She is the medical lead of CervixCheck here at CancerCare Manitoba, and she lives in Winnipeg with her husband and 2 children. So Dr. Kean, thank you for sharing your expertise with us today. And without further delay, we will invite you to speak on how HPV triage enhances cervical cancer screening in Manitoba. Dr. Kean.
Thanks, Dr. Turner. I appreciate the introduction. So just to get the formalities out of the way first, I have some disclosures here. I am an employee of CancerCare Manitoba, and I do have relationships with AstraZeneca, Merck, Novocure, Tesaro, and Pfizer, largely in the form of recruitment for clinical trials. I do have patients who are benefiting from clinical trials supported by these companies. I have received a speaker's honorarium for a lecture at the Canadian Association of Nursing Oncology conference. And like I said, I have patients enrolled in the trials by these Merck, Novocure, and Tesaro, and we have follow-up research from trials with Pfizer, AstraZeneca, and Merck, although no longer actively recruiting. I will not make any therapeutic recommendations for medications that have not received regulatory approval, and I will not directly discuss drugs marketed by any of the above mentioned companies. In terms of learning objectives, I'm hoping at the end of this presentation that you will understand the role of human papillomavirus, which I will refer to as HPV from here on in cervical cancer development, summarize the benefits of the eligibility for, as well as evidence to support HPV triage, which is the model we're going to be moving towards, communicate key messages about HPV and counsel patients accordingly with HPV positive results. I think the majority of people here are primary care, so this is going to be a very important role that you guys have. We'll talk about managing cervical cancer screening test results and how to access more information after the webinar is over. So in terms of abbreviations, HPV is probably the one that I'm going to use the most. Human papillomavirus is a little bit of a mouthful, and I'll call it that from here on in. High-risk HPV, I tend to call just high-risk HPV, but those are the subtypes that are most likely to cause cancer. Reflex testing and triage testing are what we're talking about today. And reflex testing means that the lab will decide which patients qualify for HPV testing. It won't be something that you have to order. It'll be a reflex that's done based on a pathology result or a cytology result. And then the triage testing is the same thing, but we're using triage, a reflex testing as a triaging tool for deciding who needs to see us in colposcopy. So. Without further ado, I'll talk a little bit now about HPV and cervical cancer. So cervix cancer is an interesting disease. The burden in Canada is about 1,400 women a year and 400 women die. That's about 1.3%. So it is moved fair ways down that kind of list of cancers that are prevalent in Canada. And the big shift in this has been with the advent of cervical screening in the form of pap smears. And that has really revolutionized cervical screening or cancer outcomes over the last really 75 years since that happened. So that's the conventional pap smear. There's been a little bit of progress in terms of using liquid-based cytology now and then taking that next step into HPV triage. We do still see outcomes in developing nations that are disastrous for cervical cancer, though. And this is a very difficult disease because it tends to impact younger women, often with young children or dependent children still. So it's not the, I mean, not that anybody deserves cancer more or less, but you know, it's not the 80-year-old ladies who have lived a full life, right? So the socioeconomic impact of cervical cancer can be quite significant as well. It is almost exclusively caused by HPV, and as you can see in the pie chart on the right, cervix cancer is the majority of the cancers caused by HPV, but there's others that are there that we have to keep in mind. And so, you know, when you're talking about HPV and triaging and testing for HPV, these other things are in the background as well. And as we move forward with a goal of eliminating cervical cancer, which CPAC has outlined as a very achievable goal, I think we're going to see oropharyngeal cancer in men is actually likely going to surpass cervical cancer as an HPV-mediated disease in the next decade. Hopefully, HPV vaccination will temporize some of that, but we'll see how things evolve. In terms of the disease burden, this is just demonstrating that cervical cancer as the diagnosis, as the endpoint, is kind of what you see above the water, but there's a lot going on below the water. And for every cervical cancer diagnosis, you likely see about 10,000 abnormal pap test results and about 10,000 colposcopies. So the goal, or sorry, for 50 cancers. The goal really here is prevention. And this is why cervical screening is so effective, is because we have this prodromal or this pre-invasive phase where we have an opportunity to intervene. And so a lot of the depth to this, or the groundwork, is being done before you get to an invasive cancer. And HPV testing, as you see, is going to be a step in that. So the biggest risk factors for cervical cancer, really the only risk factor in my mind, is persistence of high-risk HPV infection. So you get an HPV, not all of them are high risk, there are certainly low-risk ones, and we'll talk about that a little bit. And if it sticks around for too long, those are the patients that are at risk of developing cervical cancer. Indirectly, no pap test for 5 years or more is a risk factor as well, but it is indirect because you have to have the persistence of the HPV in order to get the cancer. If you don't have a high-risk HPV and you don't happen to get a pap test, that does not necessarily increase your risk of cervical cancer. But if you have a high-risk HPV, like I've said, we have many opportunities to intervene through adequate screening and eliminate high risk or pre-invasive disease before it becomes a cancer, and eliminate that high risk HPV. So patients who are not getting routine pap screening are at risk of having a cancer that's not identified early enough. I can't say this enough. Cervix cancer is exclusively caused by infection with persistent high-risk HPV. And just to give you an idea, there's about 160 HPV genotypes. There's a little phylogenetic tree in the middle there for those of you who remember the basic science, and it shows you kind of all the different branches of the HPV family tree. Only about 40 of them will infect the anogenital region, and about 14 of those are classified as high risk. The most common high risk ones are HPV 16 and 18, and those are going to account for probably 75 to 80% of the burden of cervical cancer. But there's a couple of other high risk types that are thrown in there as well. There's some low risk types as well. And they are very rarely involved in the development of cancer. More commonly, these ones are causing genital warts or low-grade cervical changes. So the patients that have an LSIL for a couple of years and then it goes away, low-grade lesions are not likely to become malignant, but they are reflective of active HPV infection with what is likely a low-risk strain. Most HPV infection is transient. It is cleared or suppressed by cell-mediated immunity. It can take up to 2 years. So, you know, I come across this a lot, and patients are frustrated in colposcopy. They come for 1 or 2 visits and they say, why isn't this going away? What's wrong with me? Why can't my immune system fix this? You told me it would. But 2 years is not uncommon to clear HPV, whether it's high risk or low risk. I used to explain as if, you know, HPV is the common cold of the cervix, although COVID has changed that milieu a little bit. But everybody gets HPV, everybody gets the common cold. They have some symptoms while they have an active infection, such as runny nose, cough, sore throat, you know, and the parallel in HPV would be low-grade dysplasia, and then it's cleared by 90% of women within 2 years. There is a subset of women that will have actually a higher risk infection that's not actually, say, a common cold, and this can trigger neoplastic progression. And the HPV type is the strongest factor that affects viral persistence. And HPV 16 in and of itself, if you have HPV 16, you have an absolute risk of getting CIN3 or high-grade dysplasia of about 40%. And just to give you an idea of context, having a diagnosis of high-grade dysplasia has a risk of about 30% of progression to malignancy if it's untreated, but that timeline tends to be about 20 years. So this is why even if you have high-grade dysplasia, you potentially can have many, many, many opportunities to intervene and prevent that development of cancer. In terms of transmission, it's important to keep in mind that any recent or past sexual contact can transmit HPV. This includes wanted and unwanted sexual contact. It can be intercourse between a man and a woman and a woman, or a man and a man, oral or digital contact, or sex with shared sex toys. HPV is essentially a skin-to-skin contact disease, and sexual contact tends to be skin-to-skin. But it can be any type. Partner sex is irrelevant, and like I said, wanted or unwanted. And this is really important when you're counseling patients, because our algorithm will say that patients that have had no sexual contact don't need cervical screening. But you have to be very explicit. And is that, you know, a lot of patients will say, well, sexual contact is a penis and a vagina, and that is absolutely not the full extent of it. So you have to be quite clear, you know, is there any touching, any oral or digital contact? It can be with a man, it can be with a woman. The sex doesn't necessarily matter, and it would include sex toys as well. Vertical transmission from a mother to a baby is very, very rare, but there are cases of infant papillomatosis that is associated with HPV infection, but I've never seen that in my career. It's exceptionally rare. So. In terms of the progression, because HPV comes and goes and so many people get it, what typically happens is you have it for a little while, you have some changes that may manifest as low-grade dysplasia or may not. You may have no changes, and then your immune system is going to clear it. And you can pick up multiple HPVs in the course of your lifetime, and you can clear them or not clear them. So this, again, gives us many opportunities to intervene. You can look at HPV vaccination prior to any sexual activity, and that's going to give you the best protection, because that's going to cover a large chunk of the high-risk strains. So that way, when patients are encountering HPV, they're not going to contract the infection in the same way. And then after infection, cervical screening through cytology and or HPV is looking for the impact of the virus or the presence of the virus, which is going to indicate risk for patients. Low-grade dysplasia most often is going to go back the other way and clear the HPV. High-grade dysplasia has a slightly higher risk of hanging around and turning into invasive cervical cancer. But that is still not an absolute. We treat high-grade dysplasia because we like a very healthy margin of safety, but it doesn't mean that if you have high-grade dysplasia, you will have a cancer. Certainly there are patients that are going to clear that on their own. This is my favorite graph of all time. Leslie's probably heard me say it about 100 times, that I think very effectively demonstrates the efficacy of screening in HPV-mediated disease. And the assumption here is that most patients are going to have a peak of HPV infection when they start having intercourse or having sexual contact of any type. And so kind of in that 15 to 20 years, you're going to see a huge peak in the prevalence of HPV infection among a population. But you can see in the green line that it's not until about 28 or 30 that we're starting to see a peak in the prevalence of dysplasia, which is high-grade dysplasia predominantly. So, you know, if patients start PAP screening at 21 or even 25, this can show you that there's a very good margin of safety to detect pre-invasive changes and give many opportunities to treat it before you end up at the invasive cancer, which is, you know, even 10 more years down the road at 40 or so there. And so if you take kind of the onset of screening at 21 or 25, and then the onset of cancer at 30, even with screening every 3 years, there's lots of opportunities to intervene. So this is my favorite graph. HPV is super common. When patients come to me, many of them are devastated that, you know, what does this mean? Is my partner cheating on me? It doesn't have the same implications of a sexually transmitted infection like chlamydia or gonorrhea. Although it is technically a sexually transmitted infection, but everybody gets it. What I say to patients is, HPV pretty much means you have had sex once. And if you're in a colposcopy clinic, all it takes is one. You could have had sex when you were 18 and never had it again, or sexual contact at 18 and never had anything again. But if you picked up HPV then, you could be in a colposcopy clinic 10 years later with a high-grade dysplasia, because it needs that timeline to develop into high-risk disease. And like I said, it only takes once. So if your HPV that you got at 18 is hanging around for 10 years, you're the patient who's going to have high-grade dysplasia 10 years down the road. And by age of 80, approximately 80% of the population has had some exposure to HPV. So that's quite significant. And the thing to keep in mind again is that timeline. So if a woman comes to you with an HPV positive test, it doesn't mean she got HPV in the last month from her partner. It means that she could have an HPV that's been hanging around for 10 years. And that is a really key concept when you're counseling patients in primary care, because they're all very worried that their partner's cheating on them. So right now, what we're doing and what we've been doing for decades is looking at cells on the surface of the cervix and seeing, are they dysplastic or not? Are they abnormal looking or not? And what HPV testing is looking at doing is kind of backing that up a little bit and seeing, is this virus even present? Do we need to worry about any changes we see, but is the virus even present? And if the virus is not present, then we're not as worried about cervical cancer risk. And there is some difference in terms of kind of sensitivity and specificity, which I'll talk a little bit about in a little bit. So right now our screening guidelines are cytology based. So we're looking at the actual cells on the surface of the cervix. Most women between age 21 and 69 who have ever had any sexual contact should have cervical cancer screening every 3 years. This does include transgender non-binary patients with a cervix or a neocervix. So any person with a cervix should be offered cervical cancer screening. A neocervix is a very uncommon procedure. My understanding of transgender medicine is that sometimes they will create a neocervix with the penis, and those patients should access screening, but that's not the most common procedure that's used for gender defining operations. So right now, most of you in primary care are likely very familiar with this algorithm. LSIL or ASCUS, you repeat the PAP test in 6 months. If it's negative, you repeat it 6 months again. If it's persistently negative, then you return to routine screening. And if you have 2 abnormals kind of anywhere in that 6 months algorithm, then the patient is referred to colposcopy for further assessment. What we're proposing is HPV Triage, which is going to take a subset of these patients with an LSIL or an ASCUS, and instead of repeating their PAP test, to test them for HPV and see where their risk is. There's a couple of different approaches to HPV testing. You can use it in a triage method, or you can use it as in terms of primary screening. And in the States, a lot of the guidelines from the ASCCP will use it in combination with cytology. So it's called co-testing. So if you're reading a lot about HPV algorithms, then you may see this. So, I mean, it's my pipe dream that in Manitoba, we end up with primary HPV testing, hopefully. I don't even want to comment on timelines, hopefully soon, but we're not there yet. I'm grateful that HPV triage is coming in as hopefully a stepping stone to primary HPV testing. But what that would be is looking for the HPV subtype of high risk, either alone or in combination with cytology, and using that as an algorithm. And that actually will allow you to extend your testing interval to 5 years. And what you see with both of these algorithms is you'll probably have an increase in referral to colposcopy, the first kind of set of patients that go through. And then on subsequent rounds of testing, so after the first 3 or 5 years, you'll actually have less patients who are referred to colposcopy. Just because of the nature of the test. HPV testing is a very specific and a very sensitive test, so it's excellent for that. Cytology itself is not very sensitive. It's actually only about 50 or 60%, which is why you have to keep screening patients again and again in that interval. But it is very specific. If you have abnormal cells, you almost certainly have abnormal cells, whereas HPV, you lose some specificity because you could have the virus, but not necessarily the end outcome, which is high-grade dysplasia or cancer. You may not manifest that. You can also use HPV as a test for cure post-treatment in colposcopy. So after a patient's had high-grade dysplasia, has a LEEP or a laser procedure, then we can test them. And if they have persistent high-risk HPV present, then we're more worried about them. If they have cleared their HPV with treatment, then again, that's a good test for cure. So these are kind of the 3 different things that you'll see in terms of where we can use HPV testing. Like I said, HPV testing is more sensitive, but less specific compared to cytology. But the numbers are small. Sensitivity for HPV testing, depending on the study, there was 4 really big ones, ranged between 90 and 100%, with most of them 95 to 100%. Specificity is about 90%, but it's much higher, like 98% with cytology. So we're talking small numbers in the difference. HPV is more reproducible than cytology because it's much more objective. If you're a pathologist and you have to look at some cells, you have to make a decision and say, these look high grade to me, these don't look high grade to me. And, you know, there's studies that demonstrate that even the same pathologist looking at the same slides kind of weeks apart may call it slightly different things, because there's a lot of nuance that goes into reading cytology. HPV testing is much more objective. The genetic material is there or it's not. It's a positive test or it's a negative test. So there's not that human error potentially involved there. HPV testing does offer greater protection against adenocarcinomas as well, because adenocarcinomas can be higher up in the cervical canal. So a traditional PAP test looking at cells may not catch those abnormal cells, but if the HPV is there and the patient's referred to colposcopy, then the hope is that their adenocarcinoma will be detected through colposcopy and earlier referral to colposcopy because of a high-risk strain. What we're proposing to use in Manitoba is the Roche-Cobas test. And what this test is going to do is test for 16 and 18, as well as 12 other high-risk HPV subtypes. And this is a really important thing to keep in mind, because what a lot of patients think is, oh, well, my HPV test is negative. I don't have HPV, therefore I don't have any risk, or I didn't catch this virus, and all of kind of that other stuff that goes along with it. What the test is testing for is high-risk HPV only. It is not testing for low-risk HPV. So if your patient has a low-grade dysplasia or even a high-grade dysplasia with a negative HPV test, they probably have one of the other high-risk types or a low-risk type. They almost certainly have HPV if they have dysplasia. And so what this will report is it's going to pull 16 out separately and 18 out separately, because those ones are the most important ones in terms of epidemiology of disease. And then it's going to kind of lump test all of these other ones together. So your report will say HPV 16 positive negative, HPV 18 positive negative, or HPV high risk other positive negative. And it could be any one of those 12. We don't tell you what it is. It doesn't really matter clinically. So who is going to get this? Eligible patients will be anybody 30 or older who has an ASCUS PAP test. So instead of going into that algorithm where you're getting another PAP in 6 months, the lab will reflexively test them for HPV. And the same thing with 50 or older with an LSIL. So if somebody is 30 or older with an ASCUS and they get an HPV negative result, that's very reassuring. We have a low-grade abnormality with no high-risk HPV. So that's not a patient that I'm worried about. Same thing in 50 and older with the LSIL. Not eligible will be the younger patients. So the 21 to 29 cohort for ASCUS, or 21 to 49 with an LSIL, and high risk or high-grade dysplasia on a PAP will automatically need to be referred. There's no value in HPV testing for high-grade dysplasia because they almost certainly have it, and they definitely need to be assessed by a colposcopist regardless of HPV outcomes. The reason we don't test the younger cohort is because these are the patients who are at that blue peak of the HPV graph, if you remember back to my favorite chart. Because they're almost certainly going to have an HPV infection. These are a younger patient population. They're most likely, with some generalizations, more sexually active and encountering more HPV for the first time. So when they have an LSIL or an ASCUS PAP, it's almost certainly because they have an HPV, but these patients are the ones who are most likely to clear it. I'm much more worried about a 50-year-old who still has an HPV that's hanging around and has a persistent LSIL PAP. So that's why we're going to use HPV triage for those patients. So what the algorithm will look like instead is exactly the same in the younger cohort, but in the older cohorts, if they have high-risk HPV negative, they're going to go right back to routine screening. So you're not going to be bringing them in every 6 months anymore. They're going to go right back to that 3-year routine screening. If they're high-risk positive, they're going to go directly to colposcopy. So again, they're not coming back to your office in 6 months for another test. They're coming right to see me in colposcopy because we know they're at higher risk because they have this high-risk virus. The invalid ones will repeat in 6 months, but I suspect those will be very rare. You're not going to see very many of those. LSIL, the algorithm is going to look exactly the same, except it's going to be a different age cutoff. If they're over 50, if they're HPV positive, send them to colp immediately. Benefits of HPV triage, I think I've convinced most of you, but it's going to decrease time to colposcopy because instead of the anxiety of waiting for that second test and what does it mean, and I'm not sure, they're going to go directly to colposcopy if they're high risk, but they're also not going to go directly to colposcopy if they're lower risk. So there's also going to be a section of patients that aren't going to burden our colposcopy clinics in the same way. So hopefully our referral times will be faster. It will prevent overtreatment because somebody who does not have high risk HPV doesn't need any treatment. And like I said, it'll reduce patient anxiety, both in terms of waiting, and it's a little bit more absolute. You do not have a high risk HPV. You don't need to worry in the same way as if you do. Just in terms of kind of the burden that it will decrease is about 40 to 50% of women with a low-grade Pap test are positive for high-risk HPV. And this is from the ALTS study, which was looking at low-grade dysplasia. So the other 50 to 60% of women won't be coming to colposcopy. So all of those ASCUSs and LSILs you guys chase, thank you, won't necessarily need to come to colposcopy. In terms of Manitoba, these are the numbers that should have an impact. So ASCUS greater than 30 is about 2,200 patients, and LSIL over 50 is about 440 patients. So that's about 2,600 patients that are going to be impacted by this. This was in 2018, so annually will end up in colposcopy. This is just another way to look at the algorithm in Flowsheet. So these will all be available to you. How is this going to get reported? So the lab will issue you one report. You're not going to be getting separate pieces of paper and trying to make sure that you get the right reports for everybody. You're going to get one report. It's going to have the Pap test and cytology interpretation, and it's going to have HPV positive, negative, if applicable. It's still going to have the recommendation and the educational notes that our excellent pathology colleagues have been providing us with all this time. So if you see an ASCUS and the patient's over 30, the next line will be HPV positive or negative. And then you can decide with that one sheet of paper what this patient needs in terms of referrals or routine screening. Okay, this is just the screening history. We didn't have a sample report to show you just because the computer is still trying to put these together for rollout for this change in practice. But the CervixCheck screening history is going to look like this. So you guys know that it has a specific date instead of 1 month ago or 2 years ago or whatever. We just do it this way for teaching purposes, so we don't have to change it every time I talk to somebody. So you'll have cytology result, atypical squamous cells, HPV test result, high-risk HPV positive, and then the next line is going to be the breakdown: 16 detected, not detected, 18 detected, not detected. So this patient had an ASCUS and had HPV 16 positive, so she's going to need to go to colposcopy immediately. I think we talked about most of this as I talked. And then this is essentially how things are going to look. The lab processes the specimen. It's going to go back to primary care or whoever did the PAP, and then you're going to disseminate that information to the patient. If you order the test, you tell the patient about it, which makes sense. And then the screening registry is going to get it as well. And that's not going to change. And then we'll still be in contact with primary care as needed, as well as with the patients as needed, depending on the specific results. We send letters to primary care providers and patients as needed. So the high-risk HPV positive letter will be going to the patient, and this is what it looks like here, and there'll be a brochure to explain abnormal results. And this is just kind of a fail-safe, so that if their primary care provider didn't see it or something happened, that the patient will be notified of these higher risk outcomes as well, and then they can come back to you and ask for an appointment or referral to colposcopy. Okay, so in terms of key messages, HPV is very common. I think this is the most important one, and there's so much stigma around HPV and its implications as a sexually transmitted infection that we really need to normalize HPV. It's easily spread. Lots of patients have it. Most patients it's going to clear on their own, and very few people who have HPV are going to go on to get cancer. It's impossible to know where you got it from unless you've only had a sexual contact once in your life. Then you can assume that that's where it came from, but it doesn't mean that your partner's cheating on you or anything like that. Referral to colposcopy will be made, and then we'll make further decisions there. Patients who are HPV positive still should be potentially vaccinated against HPV. I think everybody should get an HPV vaccine, so that's kind of a broad statement. Okay, Leslie, I think you're going to do this. Just a little bit of a poll. Clinicians should request screening history from CervixCheck prior to screening a patient. True or false? Can't see what it's doing, Leslie, so I don't know if I need to.
So just so folks know, you've got 30 seconds to add your answer in, and then we'll talk about the results.
Okay, so most people said true. I would agree with that. It's always a good idea to know what the patient's screening history is before you see somebody and decide if they in fact need it. Because just because a patient books to see you for a pap smear doesn't mean that they actually need a pap smear. And we shouldn't be screening patients more frequently than they require. The converse is true. If you're seeing somebody who is not up to date on screening, then getting that history from CervixCheck is also useful, because you can share that information with your patient. Okay, so here's a case study. I'll just read through it. I'm being mindful of the time. I think I only have 5 minutes left. So Jane is 30 years old, and she just had a PAP that is reported as atypical squamous cells of unknown significance, or ASCUS. And she got reflex testing because she's 30 years old, and it says type 16 not detected, type 18 detected, and other not detected. So she is ASCUS with HPV 18 positive. Okay, so next steps, and then what interval should we be? Oh, wait. Is this supposed to do something, Leslie? Okay, sorry. I got excited. Okay, so HPV 18 positive with an ASCUS PAP. Should we return her to routine screening? Should we repeat her test in 6 months, refer her to colposcopy, or you're not sure? So again, 30 seconds to vote, and then we'll turn it off. Okay, 91% of you said return to colposcopy, and that, or refer to colposcopy, and that is absolutely right. HPV 18 positive is a high risk subtype, and those patients need to be seen in colposcopy immediately. And this is how, for those of you who said repeat in 6 months, this is exactly how we're going to streamline that referral to colposcopy, because we know this lady really needs to be seen. She doesn't need another pap test in 6 months. She's already got dysplasia and a high risk subtype. So those are 2 higher risk features, and she needs a colposcopist rather than waiting to see what happens. The reason we waited before with ASCUS is because it's of unknown significance, or it's low grade, and a lot of patients are going to clear that on their own. But now we know with the HPV testing that they're potentially less likely to clear it, or higher risk for persistence. So we need to investigate them sooner than if we don't know if they have HPV or what HPV they have. Okay, so now this is Jane, and she's 49, and she has an ASCUS, and HPV is negative. So no 16, no 18, and no other. So what are her next steps there? So she had an abnormal PAP, but her HPV is all negative. So do we return to routine screening, repeat in 6 months, refer to colposcopy, or I'm not sure? Okay. And 23% said return to routine screening, 64% repeat in 6 months, and 11% refer to colposcopy. So I'm really glad to see that this is kind of, everybody has a different opinion. So Jane is 49. She had an ASCUS. She is HPV negative. She can actually go back to routine screening. So this is, again, how HPV triage can streamline care for patients, because we know that she does not have a high risk subtype. Even though she has some very mildly abnormal cells on her cervix, the risk of that doing anything clinically significant is very, very low, because she has no HPV, or no high risk HPV. She might have a low risk HPV, which explains why she got it, but the low risk subtypes are not the types that are going to be causing cancer. And so what our goal with cervical screening ultimately is to find those patients that have high risk dysplasia or high risk of developing a cancer. We're not looking to find everybody that has an abnormality. And that's the kind of the shift in thinking, particularly once we have HPV in our back pocket. Is I'm not worried about patients that have a low-grade abnormality and a low-risk HPV, because chances are they're going to clear it and they're not going to develop a cancer. And what we want to do is stop seeing all of that subset of patients in colposcopy, so that they are not stress to the patients, they don't potentially get treated, they're not a burden to the system. There's a lot of benefits to keeping that subset of patients out of colposcopy, and this is exactly how HPV testing is going to help you. Okay, now what's this one trying to tell me? Sorry. So Aaliyah is 45. She has an ASCUS HPV negative, 16 not detected, 18 not detected. If you go back in her history, you can see that Aaliyah 3 years ago had a biopsy that said moderate atypia. So I'm assuming that's CIN2. And then she cleared that on her own. Prior to that, she had some low-grade lesions. So she's had 2 negatives, and then now she's presenting with an ASCUS with negative HPV test. So next steps. Oh, sorry, I got excited. Can I go back, Leslie? I don't know if I can now. Oh, wait, here we go. Okay, so here's Aaliyah. So return to routine screening, pap test in 6 months, refer to colposcopy, I don't know. Return to routine screening. Excellent. Some people said repeat in 6 months, but she's HPV negative. Again, this is that subset of patients that we're not necessarily worried about. Now, for Aaliyah, she has had a diagnosis of high-grade dysplasia in the past, because we do consider CIN2 to be high-grade dysplasia. This one is a little bit vague. She may have a recommendation for annual screening because of her history of high-grade dysplasia, although she did clear it on her own with only 6 months intervals. So what I would do if you're in primary care is probably reach out to her colposcopist for a recommendation. For somebody like this, I would probably say annual screening for a couple of years and then return to Q3, but that is not evidence-based. I just don't feel that somebody who's young needs necessarily annual screening for the rest of their life. But the take-home message from that is that if somebody has a history of high-grade dysplasia, particularly if they've been treated for it in the form of a LEAP, then they do need annual screening. So our algorithms are purposefully a little bit vague when they say routine screening. That could be annual, or it could be every 3 years, depending on the patient's history. And this one is kind of getting at the same thing. So Mabel's 38, ASCUS high-risk HPV negative, but she has a history of a PAP that says HSIL. So what do we do here? It's going to be the same things. There we go. Routine screening, repeat in 6 months, refer to colposcopy. I don't know. Sorry. Okay, routine screening, yes. And we don't have it on here, but this one is a little bit of a trick question when we can interact with you guys. For her, routine screening should be every 3 years because she had a high-grade PAP, not a high-grade diagnosis biopsy and colposcopy. So there's a difference there. Okay, that's all my things. And then our resources here, they're all on CancerCare's website. You can access any of them. Screening guidelines will be there. In terms of the rollout for HPV triage, we're looking at sometime over the winter, although we don't have an exact date, hopefully in the next couple of months. And the algorithms will become available for HPV triage And I think we have a plan to mail things out to primary care providers as we get closer to that date. But Leslie will comment better on what that looks like in terms of resources. But all of our resources are always on the CancerCare website. And the other thing is a little plug for Leslie and CervixCheck is if you're not sure, you can always reach out to us at CervixCheck. You can contact us directly by phone or by email. And if you have a specific case that you're not sure how to manage, Leslie can answer a lot of them. And if she can't, she sends them on to me. And I'm very happy to help you navigate individual patient concerns. This is a good resource for HPV cancer. And this GOC resource is excellent for HPV related diseases and benefits of vaccination. And then more resources. And that is all I have to say. Thank you.
All right, thank you very much, Dr. Kean. There you go, and with your.
All right, I'm multitasking.
Yeah, well, it's always good to have live additions to our session.
Yes. This is Nora. She's visiting us.
Welcome. So thank you very much, Dr. Kean, for all this information around HPV triage. Just before I introduce our other two panelists, I do want to just note that we can see that we have a number of questions that have come into the Q&A. Just would ask folks to please remember to put your questions in the Q&A, not in the chat box. So if you could put them in the Q&A, we will make sure that we get to answer them. I will say we have a number of questions. We may not have time, but what we are committed to is to answer those questions and put them up on CancerCare Manitoba's website shortly so that everybody can see what the questions were and also get the answers, and we'll have them there long term. So in our next session, the implications of HPV triage for Manitoba labs and primary care practice, I would like to introduce two individuals who will also speak their disclosures in a minute. So first of all, we have Dr. Gabor Fischer, who's a cytopathologist and medical director of anatomical pathology with Shared Health Diagnostics and the department head of pathology at the University of Manitoba. And he'll speak on how HPV triage implementation impacts Manitoba labs. And second, we have Catherine Capina, a physician assistant with Elemental Professional Health Center, which is a Winnipeg Regional Health Authority, or WRHA, primary care interdisciplinary team development initiative. There's a development site who will speak about how HPV triage implementation impacts primary care. All right, so next slide for that, please. And just to Dr. Fischer and Catherine to speak your disclosures.
Thank you very much, Dana, and thank you, Sarah, for that great summary. So I have nothing to disclose. I have no financial support. I have no mitigating potential bias to disclose. So we can move to the next slide. So when it comes to lab testing, I just want to emphasize that don't forget that all of this analysis is performed in an accredited environment. All the participating labs are MANCAP and CAP accredited, so accredited by the provincial accreditation system, also accredited by the College of American Pathologists. The testing platform, the Roche Cobas testing platform, I have no affiliation with Roche and I have no financial relationship with them. So I am free to say that this is a really good method. It's an automated, highly reliable, reproducible system. It performs really, really well when you compare it to the competitors. There is no room for inter-observer variability in this testing platform as opposed to the cytology. You know, cytology, many times these cases, the ASCUS and the low-grade cases, they are really subjective. There is a high inter and also there's a high intra-observer variability. So different pathologists may come up with different results. In certain cases, even the same pathologist may change opinion on a given day. As opposed to this test, it has a great analytical sensitivity and specificity. One of the reasons is it only has a minimal cross-reactivity with the low-risk HPVs, and this is actually one of the reasons it performs better than the competitors. And it's mostly limited to mixed infections by different HPVs. So if someone has infections by multiple low-risk HPVs, that's the only scenario when occasionally false tests can happen. It also uses a beta globin as an internal control, and this is critically important. So in case you are wondering, so what happens, the vial gets tested for cytology first, and the remaining material will go through this testing process. If the remaining material doesn't have enough cells for testing, this system will flag that. And in those cases, you will get an invalid result because they measure the number of the cells in the vial and in the testing material. And if there is not enough left there, the results will be invalid as opposed to positive or negative. Next slide, please. So the workflow in the labs, the cytology is still the first step and the cornerstone of the analysis. And the testing is reflex in a sense that certain diagnostic categories automatically get triggered for molecular test. And it also reflects in a sense that the molecular test is not the first step of the screening process, as it will be in the primary HPV screening, but we are not there yet. HPV test, as I mentioned, is performed from the residual sample. You will get an integrated report. This was a common goal and a top priority for us. We didn't want you to be in a situation that you will get your cytology result on Wednesday and you will get your HPV result on next Monday, and you have to integrate and put that both together. So you will have one report. For the very same reason, since the cytologist, cytopathologist, when they arrive at the diagnosis, they have to trigger an additional test. There will be some impact on the turnaround time, but we're working it would be minimal because we have to add one test to the steps. Other than that, all the cytology criteria and interpretation remains the same. You will just get one additional report and information, and also same educational note. And I think that's a summary of the lab side. Thank you, Dana.
Thank you very much, Dr. Fischer. Okay, over to Catherine Capina.
Okay, thank you, Dr. Turner. This is my presenter disclosure slide, and I do have one disclosure, which is that I am a member of the CancerCare Manitoba Primary Care Advisory Committee, Prevention and Screening. I have no disclosures of financial support and no mitigating potential bias. Next slide. Okay, so I'm here to talk about the implications of HPV triage for primary care providers. I'm going to try and keep this really short so we can get to some questions. Essentially, it's not going to change our basics, which will continue to be encouraging safe sex practices, suggesting regular STI screening, assessing for eligibility and suitability for HPV vaccination, and recommending immunization when applicable, and encouraging regular cervical cancer screening with Pap tests. But it will improve patient education by allowing us to not only give patients information regarding what their Pap test result demonstrated, but also what their high-risk HPV status is and what that means for them moving forward in terms of risk of progression and the need for further testing. I also think that we'll likely get more questions around HPV, and I think that this is an excellent opportunity to dispel some of the myths and stigma around HPV. And Dr. Kean listed some points to review with patients, that it's very common, easily spread, et cetera, et cetera. From a patient perspective, it should reduce anxiety, prevent overtreatment, and optimize patient time. So these changes limit the need for colposcopy to only those most likely to benefit, limits the need for repeat PAPs in certain populations, and colposcopy oftentimes can be quite uncomfortable, anxiety provoking, time consuming for the patient, as well as PAP appointments. It leads to improved resource management from not just a colposcopy perspective, but I believe in primary care, it's going to help streamline the process for these patients over the age of 30 with ASCUS and patients over the age of 50 with LSIL. By returning them to routine screening if their high-risk HPV status is negative, or direct to colposcopy if their high-risk HPV status is positive. And this negates the need for the repeat PAP in 6 months until 2 negative results are achieved, as was previously done. And overall, I think we just need to become familiar with these new guidelines. Although the recommendation for next steps will be on the PAP report, it's important that we understand what those next steps should be, and so that we can help navigate our patients through the healthcare system in a timely manner and address any questions or concerns that they might have. And initially, we might need to refer to the new guidelines quite a bit until we get a little bit more familiar with them, but it's not going to take long before it becomes second nature, and just like the current guidelines are now. And as Dr. Kean said, we can always reach out to CancerCare, to CervixCheck, with any questions we have. Okay, thank you. Next slide.
All right, thank you all panelists very much, Dr. Fischer and Catherine and Dr. Kean. So now all individuals will be available to answer questions that we might have. Dr. Fischer, if you can turn your camera back on, then we can ask our questions. So the first question that we have here is, can a 38-year-old man with an HPV-associated squamous cell carcinoma of the oropharynx receive a provincially funded Gardasil vaccination? And if not, should he pay for one?
That is a hard question for me because I'm a gynecologist and I haven't treated a man in 15 years, but there's no straightforward answer. He technically can get one just because one of the caveats on the recommendations is that if the oncologist feels it's appropriate, it can be given. So that would be something I would encourage him to discuss with his primary oncologist. I typically don't vaccinate women who have had a cervix cancer. It's more the dysplasia, if that helps.
All right, thank you. And just a note for folks, if you're putting questions in the Q&A and we don't get to your question, please don't worry. We will answer your questions and put them on the CancerCare website as a Q&A in the future. So the second question, why does someone who has had normal regular pap tests and then will get a pap test come back with cancer, can it progress that quickly?
So this is an excellent question, and it speaks again to the nature of HPV. And the benefit of PAPs. There's a couple of reasons. So one of them is, remember, the PAP tests, each individual PAP test is only going to pick up an abnormality about 50 or 60% of the time. So, you know, it could be that previous tests did not detect the abnormality that was there. It doesn't necessarily mean that it's been a rapidly progressing cancer, although certainly there are the rare, few and far between super rapidly progressing cancers, and we've all seen one or two, which can really color your experience. The second is that it could be an adenocarcinoma that she has, and if it's high up in the canal, then a pap test may not be accessing it every time she's screening. So you're getting normal exocervical cells, but the endocervical cells aren't adequately sampled. And then the second part of that, I can just see it, Donna. Why does someone get an abnormal pap when in a strict monogamous relationship times 15 to 20 years? And that's exactly how HPV can behave. And that you may not see a high-grade abnormality until 10 to 15 years out, because that's when we start to see that peak after HPV infection. At 10 to 15 years, you're starting to see pre-invasive disease. So that's exactly how HPV behaves. So it could be, and I think there was another question further down that asked that, it could be HPV that you picked up 10 years ago that's causing your current abnormality on a pap test. Absolutely, it can behave that way.
So this may be related. If a patient has a previous CIN2 with a normal pap for 20 years, they're in a monogamous relationship, do they need an annual pap test until they're age 69?
So that one, you know, best evidence, if we've treated somebody for high-grade dysplasia, we recommend annual screening until they are 69. HPV testing can change that, because if we have primary testing and we have an HPV that's negative, then you've essentially demonstrated a test of cure, although we're not there yet. With somebody like this, you also can have recurrence of the previous abnormality. So it's not necessarily a new abnormality that's a problem in a monogamous or a non-monogamous relationship. So because you've had high-grade dysplasia in the past, you could have recurrence of that if you did not clear the HPV with the treatment.
All right, thank you. So I'm going to ask one last question in our time available, and then we'll answer the rest in our online document. So if a patient had a hysterectomy and a CIN3 or CIN3, is there a role for pap tests subsequently?
Yes, absolutely. If a patient has a history of high-grade dysplasia and has a hysterectomy, they still need ongoing vault screening because they can get vaginal cancers. If they have had a hysterectomy and no prior dysplasia, then they fall into the cohort of patients that do not have a cervix and do not require screening anymore. But if there is any history of high-grade dysplasia, I recommend ongoing screening of the vaginal vault.
Excellent. All right. Thank you very much, Dr. Kean, for those answers. And again, thank you very much for Dr. Fischer and Catherine for joining us. Also, thanks to all of you for your participation. We have a lot of good questions that are remaining to be answered. And so I would encourage you to check back to the CancerCare Manitoba website and follow up in a few days, and we'll get those answers to you. I think anybody attending will find that the questions being asked and the answers are very helpful and really fill out some really challenging questions and corners of things that might come into your practice. So thank you for your participation. Following this webinar, you'll be receiving a link inviting you to complete an evaluation. If you would like a certificate of participation, please indicate that on the evaluation. So the filling out our evaluation is key in order for you to get your certificate of participation and your mainstream Pro Plus points. The webinar recording will be posted on the CancerCare Manitoba website. The link is here on your screen. And again, I want to thank Drs. Kean and Fischer and Physician Assistant Catherine Capina for sharing their expertise. I'm also going to say thank you very much for the screening program folks, Leslie Baldry and Naomi Liu, who are two of our awesome educators who you will probably be communicating with if you reach out to CervixCheck as well. They are instrumental in a font of knowledge in this area. And thank you, everyone in the audience, for your participation and your great questions. So thank you very much. Have a good afternoon.